check yes for asthma throughout something. Okay, for an inhaler. Do you have your inhaler? Have they had an asthma
What a shame.
before the dental office?
Yeah, what triggers?
What triggers their asthma attack? When was their last one? We're getting all the wet lies wondering how.
มึงมาดูนไว้ครับ
That's pretty good. I like all of those. That will do you a lot of good. There's one other one we'll talk about that's a possibility as we go through. It looks like I left pop R on that. That means proof of preparation for respiratory disease. I categorize all my things. I usually take that off. Okay. Chronic obstructive pulmonary disease, COPD, is primarily made up of emphysema and chronic bronchitis.
Oh, dang it.
Yeah, not asthma.
Emphysema
Asthma's not any
and chronic bronchitis.
So 3 of them, 2 of them had asthma, and 1 of them had TB. I have TB in there, fortunately. Okay, you're performing dental hygiene care on a patient who suddenly begins wheezing during the appointment. You know from the patient's health history that the patient has asthma. You terminate the procedure and raise the patient's dental chair to the upright position. Which of the following actions should you take next?
Hopefully administer to.
Rescue inhaler.
Not the oxygen.
That was an online question. This is a good one. A surgical mask prevents inhalation of TB droplet nuclei, and therefore standard precautions are sufficient to prevent disease transmission. True or false? Catalina, tell us. False. That's true. It is not. This is why this is one of the
False, that's true.
scariest systemic diseases that we could have, along with a couple other things. So we really need to, this is pretty important. We don't have a huge problem with TB in the U.S., but it's becoming more of an issue, probably because of the travel. Which of the following is the most common risk factor for COPD? I hope you got this one. Cigarette smoking.
Makes sense.
Okay. Okay, before I show this, I think you may have already got this. Let me see. Has everybody seen this final printout of your exam week?
Oh no, let me take it.
What?
She got her way again, huh?
Gosh, dang it.
We really wanted PAP on Monday.
You did?
That was our
No.
so that we could
My biggest worry for you is 2 on Thursday.
We can't switch like med conference.
You can't, don't even, you can't even believe what's gone behind this little picture right here. So it has, this is like, yes, federal law.
What?
Yeah, no, it's very, I can't even tell you. So it will not change from this unless the world ends. Okay. So, yes. So now you know, but it's none of it's my fault. I just said I'll do whatever you tell me to do. Okay. I'm going to go through this really quickly because we have a lot of respiratory diseases to hit the high points, so you know the high points. But this is incredibly important, and you're going to be doing one more in class, and you're going to be doing one more in the final, and I want everybody to ace it. You did pretty good, but I gave some grace too. So let's just talk about, and this will also prepare you for this summer when you're one-on-one with the faculty as your patient in your OSCE exam. So the more we go over this, the better you're going to be at it, the more comfortable you're going to be. So is this an update? Yes. You don't have to ask any more questions on that. Yes. Except for you need to know, when should you do an update? Do you guys remember how often should we do an update?
You do it every time.
Not almost every recall. If you just saw them last week, you don't have to say it's an update again.
Okay.
Because it probably hasn't changed, but you got to give them that option. If it changes, then it becomes an update. If it's changed at all and you have to type it all, then it would. But otherwise, you just do that every 3, 4, 6 months, whatever. Yes.
So if we had seen them last week, we wouldn't have to do anything on this?
You would have to look at it, remember it, and you'd have to say, have you had any changes since last week in your medical health? Not very many people would not remember what happened in the last week. There might be a person or two that, like that lady who didn't know that she didn't remember to tell she had a stroke 2 weeks ago. But most people don't. And if you want to go one step farther, have you been to the doctor or the hospital since I saw you last week? You could say that. And if they say no, then you're pretty good to proceed. You don't have to go on. However, when you have your faculty come over, you've got to remember, often it's so easy to say, it's the same as it was last week. And I'll say, yeah, but I wasn't your instructor last week, so I don't know what's on your health history. So you need to give an update, say, nothing has changed since last week, but this is what they have, and they were controlled at that point, and they're controlled now.
Wouldn't it just be safe to always ask 2 weeks or 2 months ago, has anything changed?
Oh, you always should ask if anything has changed. But some people, that's not good enough for. So always that question. Always, always. Never, and you'll hear it at the dental office. The problem is that's the only question at the dental office. I heard it the other day when I was there. Have you had any changes in your health since we saw you last? That was it. That's not enough if it's been a while. Because they, like I told you, my brother-in-law didn't think it was a change in his health to have a total knee replacement and several surgeries on his knee, because that's not the inside of him. It's his knee. He needs surgery, and it's not. So, but that could affect our treatment if he had something else. We need to give him antibiotics. So that's a good one to know. Okay, what are, right here, this, yes. Let's see, I can't highlight it. Okay, because are you now, or have you been in the past year under the care of physician? Yes, that's pretty straightforward. But what are there's 2 questions that are very good to ask, and then there's a couple more questions that I didn't take off if you didn't ask them, but I want to remind you that it's really good. So raise your hand so I can hear you, one person at a time. Is that me? Okay. Okay, yes, Sandra.
How often do you see your physician and why?
Okay, why and when? And then what other information might be good to have if we have an emergency?
Contact information.
Name and number. Okay, that's really, you'll note that in a lot of your health histories, they have the name of the doctor and the number. That's really helpful when we need it and we don't have the patient to be able to help us. Okay. And then what would you ask on, have you had any serious illness, operation, or been hospitalized in the past year? 5 years. And it does say if yes, how long ago, so. Yes.
What form?
What for? Basically out of that, that's a huge list. Which of these? Is it illness, operation, or hospitalized? Did you answer yes to this for? That's the main thing. And it says, if yes, how long ago? So we need both of those. And since that didn't have the what happened, then we also need the when. It didn't have the when either. So it would have been what and when are the main things I'm looking for there.
Any lasting conditions as a result?
Okay. Depending on what they answer, if they say I broke my leg, I had a compound fracture, well, I guess they could have lasting results from that too. But if they had hepatitis C, yeah, and I was hospitalized, they could have definitely chronic. So he's saying any lasting results from whatever happened. Kind of depends on what they tell you. Yes.
What type of treatment did you receive?
Yes.
How was it done?
Yes. What kind of treatment was huge? And that is what I really wanted to see was sleep apnea. Is what kind of treatment have you had any treatment? Are you having any treatment? And are you seeing a doctor? Kind of trying to figure out if they've had help. They said yes, but that was it. I mean, I know I'm getting ahead of myself, but what kind of treatment is really important because that gives us an idea on control. Okay, let me get rid of that one. Let's see, page 2. Okay, here we have quite a few no's. They were taking birth control pills. What I really wanted to do is throw in that they needed to go on antibiotics, and I wanted your response to that. Some of you put it in, but it wasn't required because they weren't going on antibiotics, but some of you added that in the modifications at the end. If they were to have antibiotics, then we need to let them know, educate them that their birth control pills may not be effective and they should use another form. But you had that question somewhere else in there, so that should be good. Medications. So they listed their medications. What's missing specifically there? Dosage. Why in dosage? So you're going to get a question in the assignment today that says, what additional questions for medications do you need to ask besides have you taken it today and do you take it regularly? And that's dosage and why. Okay, so I was kind of lenient on that, but next time if it's missing the dosage and the why, you want to verify that, okay? So next time I won't be as lenient. It's really important on the medications, okay? And that will help anybody who's been soaping a lot. For anybody else or themselves, the why helps a lot. Okay, high blood pressure, most of you got that one. Basically, you're trying to establish control. Do you see a doctor for it? Have you been diagnosed? Are you taking medication? Well, they are, hydrochlorothiazide. So basically, you're just kind of establishing what kind of treatment they're having for it, and if they've actually been diagnosed or seen a doctor for it. Okay, sleep apnea. Throw out some questions for that. Besides the treatment one, now we've already.
When were you diagnosed?
Okay, when were you diagnosed? What? Or do you use a CPAP? That's a good one.
Do you sleep in an upright position?
Do you sleep in an upright position?
Do you experience dry mouth?
Do you experience xerostomia, dry mouth to the patient? Common language to our patients. Sometimes it's so hard to do because we force you to say these words for 2 years and then you get out and they're going, what? Xerostomia? What is that? Dry mouth. Difficulty breathing, laying down, yeah, that kind of, you establish that. So basically, when you do their intraoral, you're going to find out more. If they have attrition, yes.
The snoring?
Snoring, does anybody ever say you snore at night? Usually people know if they snore. Difficulty breathing when they lay down. Okay. Mostly that one, you kind of expected some modifications on that one. Okay, let's see. First one was seizure, epilepsy. Most of you did well in that. You want to, few left it out, but you want to know first, what are the couple first things you'd want to find out? If that's all you have, seizure, epilepsy, that's it. What kind? What kind? Okay, how frequent? When was the last one? I really looked for that on every single one of yours. If you didn't say when was the last one, then I deducted a little bit. Okay, when is super important. What kind was super important because it's big difference between an absent seizure and a tonic-clonic seizure. Yeah, control, treatment.
Is there anything I can avoid?
Yes, that's a really good one. Is there anyone I can avoid? Anything I can avoid to not trigger it? Is there something that triggers it? Yeah. So you guys are thinking a lot of what, where, why, when, how to establish control. Always think. If you can't think of the list you wrote or the list I gave you, just think, what would I ask to establish if this patient is controlled? And those are the things that should come up. When is a biggie? What is usually in there somewhere? And how? How are you being treated? Those are big ones. So if you can't memorize the exact wording of the questions, it doesn't matter. Just try to think, what would establish control? And when you read through the list of questions, think, is that a what, when, why, or how? And if I bold it, then I'm going to really look for that in the response. Okay. Heartburn, acid reflux went together. What are some questions we could throw out for that?
How often do you experience heartburn?
How often do you experience it?
Maybe like when was the last time you ate?
That's really good. How long should it be if they have severe GERD?
3 hours?
3 hours prior. So that would be a modification. That'd be a good modification, is eat 3 hours prior. I didn't expect you to all write that, but many of you did, and that was a good modification. The main thing with GERD is if they're uncomfortable and they have reflux when they're laying down. So what's our big modification there? Yes, semi-supine. And be sure, and I didn't, a couple said just supine, and I know they meant semi-supine by the rest of their wording, but be sure and get that semi-supine. Don't miss that word. Big difference between this and this, okay? What was the one other thing? The oral effects. What are the oral effects of GERD if they have severe reflux? Kind of the same as... Okay, if they do have a reflux event, not to brush their teeth immediately, what should they use to counteract that? Let's say it's a pregnant woman too, and they throw up from morning sickness. If they don't brush, they may rinse. Rinsing with water wasn't good enough. It helps, but that's not good enough.
Was it with baking?
Yeah, baking soda, something to make it more basic in their mouth, especially if they're having reoccurring. Okay, so then what would you treat xerostomia with? That's kind of, we're going back to sleep apnea, but Biotine rinse, some kind of saliva substitute. Biotine is what we give out here. And by the way, if Biotine was misspelled somewhere, my autocorrect does not like Biotine. It keeps doing Biotin. So if you saw that, I didn't spell it that way, but my autocorrect, and I didn't catch it, just so you know. Okay, what's that?
Hair nails.
Yeah, okay. What was the okay. So if they have acid reflux, pouring over the teeth, what's our other modification that's hands down? I looked for this one.
Don't brush your teeth.
Okay, don't brush your teeth right after, and the basic rinse with a baking soda rinse, or basic pH is what I was trying to say. Yes. Fluoride. Always think fluoride. Anytime you ever hear the word xerostomia, think fluoride. Fluoride. Okay? And I wanted to see that. I was really looking for fluoride and maybe a saliva substitute for the modifications at the end, because they're going to have problems with caries. And especially with attrition too, wear down all that enamel to the dentin, and you have acid reflux, you're going to have problems with caries. So, yes.
What was the word that's like the erosion from throwing up?
Perimyolysis. It's spelled myolysis. I always have to look at that. Perimyolysis. We'll talk about it again in fall when we talk about eating disorders. But you want to know that word for sure. Be familiar with what that means. And where is the location? This you want to remember from here on out. Where is the location of perimyolysis? Lingual maxillary anteriors. And think about this. If you reflux, you have this tongue that we can't take out like the SimLab, and the tongue actually protects all the lower teeth on the lingual. It's not the lingual, the mandibular anterior. Maybe the occlusal a bit, but it's going to flush right over your palate side, and especially the anteriors. So think lingual, just think of the process of where it's going to come, and think of your tongue as a protective area. So that's also going to always be a question. Where are you going to see this perimyololisis? I don't know if it's pronounced olisis or lolisis, but it's spelled lol. Okay. And ASA classification type. I allowed a fair amount with this. I didn't allow 2 because this patient had a tonic-clonic seizure 1 week ago, 6 days ago. So they are not controlled. Whether it's kind of gray. It's, we're sending a med consult, so that's important. Is it life-threatening? Possibly, probably not, but we're sending a med consult. So I accepted 3 or 4. It's a little tough when you're sending out for a med consult and you're not treating today. I was kind of, because it doesn't mean some people could die right then. Hypertension, 220 over 130, they could die right then. That's ASA 4. Absolutely. Somebody who had a tonic-clonic seizure a week ago may not necessarily die, but they need to see their doctor because they're already on medication, and that's really recent for being medicated. But probably not life-threatening. They didn't have a status as, not asthmaticus. We're going to talk about that today. Status epilepticus. Epilepsy. Think of epilepsy. Status is continuous. Epilepticus. So if you ever have to repeat that word again, that's... And then today we're going to talk about status asthmaticus. Okay, I hope that helps. Next week we'll do 1 more in class, get some good practice, and then 1 more. And then this summer you're going to have one-on-one with somebody talking to, as faculty are going to be your patient with a health history that you get to look over and ask us questions. I feel like you're much more prepared. I'm seeing good questions coming out, and actually I feel like you kind of do better on this kind of exam than too many. I don't know. It's a good mix though. So I looking forward to you being really safe in clinic. Okay, I was going to show you, oh yes, the results to, where's my poll everywhere? There it is. Okay, that was the answer. We're going to talk about that today, so that's a really important one. Prednisone or corticosteroids are often in the inhalers. They help asthma. Most people who have severe asthma might even go on prednisone. Nobody likes to take prednisone for the side effects, but if you can't breathe, you love it because it's going to help you really quickly. Has a lot of bad side effects, but if you can't breathe, those don't bother you as much. Aspirin. More people with asthma are allergic to aspirin for some reason.
Oh, yeah.
You probably, did you? In farm or with me?
Oh wait, maybe it was with you.
It was both.
It might have been.
Both.
Both. Yes.
Or anesthesia.
So for nitrous oxide, just a quick refresher on that. Is it just COPD that indicates use nitrous oxide?
Yeah, asthma is the only respiratory disease that nitrous actually helps. Any other respiratory disease, nitrous isn't going to be good for because they have problems breathing. When you have asthma, it's considered reversible. You go from an attack where it's acute to being able to breathe normally. So that's why the reason, and this is a board question actually, so and I think I have it later, so now you guys will all know the answer and you can do it in 30 seconds. Because it will actually keep the person calmer if there's something in the dental practice or stress or fear that will trigger an asthma attack. Nitrous is actually a benefit. So it's the only, though, respiratory disorder that is considered safe. Okay, one more question and then we'll get going. Let's see. Oh, I need to activate it, sorry. And I need to See if you recognize this question. Yep. All right, AJ, I'm so glad. I know. Okay. Okay, so that was wrong. It should be weight loss. People with TB have weight loss. Which does it include weight?
Except
Yeah. Okay. Okay, I am going to show you an asthma video. Who knows somebody with asthma? Everybody. How about severe asthma? Yeah, it's scary. Okay.
Huh? I say that every time. You pay attention to what I say.
Just a minute. No, I had the wrong one in there from last time, so it.
Pay attention. Remember what I said?
I'm missing the. I know I'm missing it again, and you're right in front of me. How do I miss it?
I thought you were having your
No, make that clear. Okay.
Bronchospasm, or the acute asthmatic attack, is a common condition found in many dental patients. The acute episodes occur when smooth muscles surrounding the larger bronchi and bronchioles go into spasm. During this episode, the lumen of the airway is considerably narrowed, causing the victim to experience extreme difficulty breathing. This results in the victim not moving enough oxygen into their lungs or carbon dioxide out of their lungs. Therefore, asthma has to be treated promptly or it can be fatal. When a new patient in the office describes themselves as asthmatic on their medical history, the subsequent dialogue history should include the following questions. What type of asthma do you have? Asthmatics have either allergic asthma or non-allergic asthma. Non-allergic asthma is frequently induced by fear and anxiety or the absence of adequate pain control. Find out if the asthmatic patient is frightened of any aspect of dental treatment because this fear alone could trigger the acute asthmatic attack. If they have allergic asthma, you should ask, what are you allergic to? Aspirin is a very common cause of allergic asthma. What drugs do you take to control your asthma? Asthmatics usually take two drugs. One is their rescue drug, commonly a bronchodilator such as albuterol, for the management of the acute episode. More and more commonly today, the asthmatic may also be taking a preventative medication such as an inhaled corticosteroid on a daily basis to minimize the occurrence of acute episodes. How often do you have asthmatic attacks? And what triggers your asthmatic attacks? If the patient says, whenever I get scared I have an asthmatic attack, and doctor, don't take this personally, but I hate going to the dentist, this patient is more likely to have an asthmatic attack in the dental chair. Sedation is indicated in this situation as a means of preventing the acute episode from developing. Have you ever had an attack that did not stop? And have you ever been hospitalized for your asthma? These questions help determine whether or not emergency medical services should be immediately activated in the event the patient has an episode of bronchospasm in your office. I strongly recommend that when your office calls to confirm the patient's dental appointment, you remind them to bring their inhaler, their rescue drug, with them to the dental office. So what do you do if the patient has an asthmatic attack during their dental procedure?
All right, Brandon, your next floor, we'll take a look what we're going to do today, and we will get started. Thank you so much. All right, Don, would you please open for me? Please. Let's see. Okay. The very first thing I did was put Don in a very comfortable position. People that are having problems in breathing prefer to be in an upright position. In addition, we had put Don's inhaler on our bracket behind him. We got his inhaler so he could start with the bronchodilation treatment. If his dilator was not successful, we had our own bronchodilator, which we would have let him use. But we were successful in treating this with his own.
So, definitive care for an acute asthmatic attack is to allow the patient to self-medicate using their rescue drug. The bronchodilator acts directly on the constricted bronchial smooth muscle, producing bronchodilation in about 20 to 30 seconds. A usual dose is 2 puffs. A second dose may be given if the patient continues to experience difficulty breathing after 5 minutes. In this scenario, once the patient recovered, he wasn't comfortable with continuing with the dental treatment.
Maybe we can reschedule. Would that be okay, doctor?
Absolutely not. In fact, I think maybe I'll give you a prescription for something to sort of calm you next time, because that's probably what precipitated it, because you said you were a little stressed.
Had he wanted to continue, it would be okay, provided that you, the doctor, and the patient are both comfortable doing so. But before returning to the treatment, find out why the episode happened. Most often we find out that the patient was scared. Treat the fear before you continue the treatment of the patient.
That was kind of a mild one that is more treatable, that you're more likely to have in your. I've never had someone have a really hard time. Maybe a little. I've more dealt with kids that have asthma attacks from running around on the playground than I have otherwise. So, okay. Okay, I wanted to mention, I put in Canvas lecture notes and assignment. So I want you to try a couple weeks and I'm going to have you give me input on the final exam. 4 points. Not 4 points, but 4 credit, 4 points. In regards to the assignments and the value, the best way to turn them in, etc. So for today, I'm not going to have you turn in the lecture notes. There's a smaller assignment that I would have had at the end of the lecture notes. But I'm going to let you decide, see if you still fill it out, if it becomes a study guide for you, if it's still helpful, but you don't have to turn it in, so that stress level is less. Or if you just don't turn it in and it's okay if somebody else did it and they don't mind sharing, what's best for you. So I want input at the end, what works better for you. Okay, so you don't have to turn that in, but it's still your study guide for the final and for the quiz next week. But there is a shorter one. So do that, and you do need to turn it in. And you can see the difference because you can see where it's linked into being able to turn it in. So don't turn in the wrong one.
So for the quiz and this final, it's better to do the longer one.
It's best to still do that one because it's still your study guide. So I would, if you do it during class, that's great. If you do it later, that's great. I just want to get your input, so be thinking about it because I want your input because I do base a lot of my future teaching on what the majority of the class likes or works best for them. Okay. So now we have to move it in this because we've done a lot of review today, but I think most of these things you're familiar with. If you need to take a break, why don't, I'm not going to stop if that's okay. I'm going to move forward and just push through, but if you need to step out, do so. Okay, I've already done that. Okay, so when reviewing patients in clinic, this was, actually we went through this. I'm going to let you look at this separate because this is actually part of the turn-in. So I'm going to just let you look at it. That's where you go. Okay, we're going to talk about TB, asthma, COPD, and just a little bit about cystic fibrosis. And in the health history, there's right at the beginning, they hit all the biggies. And one of the biggies is establishing if this patient is contagious. If they're infectious sitting in your waiting room, we want to figure that out quite quickly. And we'll make a plan, kind plan, but we won't keep them in the office. So this is up towards the top where it also has, have you had any joint replacements, and also the bisphosphonate question. So these are all at the top of Axiom. Do you have any of the following diseases or problems? Active TB, persistent cough, cough producing blood, exposed to TB. Hopefully that would elicit the responses to give you an idea. Then way at the bottom with medical problems, it's going to say respiratory lung problem or infectious disease. Okay, so TB, I know you've heard about it enough over your time, but it's basically caused by a little bacteria called the Mycobacterium tuberculosis. At least it's named well. It's a huge epidemic worldwide. A third of the world is infected. So that's, it's the one pathogen that kills more people than any other. And we still have not nearly as many, but we still have quite a few cases of TB reported in the U.S. If there ever is a TB case that's seen, it's definitely a public health concern and should be reported to the local public health location. Some ethnic populations are a little higher risk for some reason. So it is something that certainly when you go to a third world country for anything, including a mission trip, it is something that you just have to be aware of is a possibility. And but so far I have never seen anybody come back with TB from a mission trip. I think God protects you extra well. But I know my kids went to Africa for 6 weeks. And definitely they were kind of watching any symptoms afterwards for a while. My daughter and her husband went. And definitely in a higher risk area that they were. So basically, how's it spread? So it's airborne droplets of mucus or saliva. And so if anybody coughs or sneezes, and then somebody inhales it. I like this picture better because it kind of gives you an idea. So people cough, sneeze. You've probably seen the pictures of how far sneezes go. They're many feet. Cough, even speaking and singing. So it's possible. Transmission occurs when another person inhales that. This droplet nuclei is so tiny that it can fit through our regular PPEs or our regular yellow masks upstairs. That's why you need a different mask if you ever treat them. If they need to be treated, they need to be treated in a hospital setting. I'll show you a mask. It's quite the mask. So what happens to begin with is if they do inhale that, they get what we call primary infection, TB infection. And the body fights it like we talked about and creates antibodies. And most people don't actually develop an active disease process. So it's what's confusing. So that is what we call latent. So latent tuberculosis infection. You see that up at the top. So it's still alive. The bacteria is alive, but it's inactive right now for causing an active infection. So people who have a live but inactive, latent, would have a positive TB skin test because it's present in the body. The body has created antibodies, so those antibodies are going to show up when you have a TB test on your arm. But they are not contagious at this point. So, okay, active is if they develop symptoms. The symptoms that we worry about are persistent cough over 3 weeks that produces blood. And they cough so hard you have blood. You also have flu-like symptoms. So that's pretty hard. A lot of people, flu has coughs and flu-like symptoms. How do you know? It is hard. Night sweats and fevers at nights, that's persistent for a long time. So it is sometimes hard. If you have a flu that lasts longer, it would be hard to know. Usually fevers don't last 3 weeks though. Once in a while they do, so that's a tough one. Weight loss, not feeling good, malaise, you're probably not going to feel good either. So it's a little difficult to tell the difference. So the difference between active and latent, again, is somebody who's active would have a positive skin test plus symptoms. Somebody who's latent would have a positive skin test and no symptoms. So they are not contagious if they don't have symptoms. So say somebody has been exposed in the past on a trip, and they come back and they have a positive skin test, they know that they have that latent bacterium in their lungs. But it's not contagious at that time. However, active, of course, is extremely infectious. So there's different ways to find out. All of you are familiar with the skin test. You had to do it when you came here. However, if you happen to live in another country or be born in another country and get a vaccine for TB, which they do in other countries, you have created antibodies for TB, and you will always be positive to a skin test. And people who know they've had that vaccine just go and have a chest X-ray instead, because they need to show that they don't have TB. So people know if they've had that. Usually we have somebody in our class who's had the vaccine from growing up in another country. Yes.
Why don't they have the vaccine here?
That's an excellent question. Because we have such a minimal amount. I think it's a nice one. Here it is, right there I looked that up because that was the exact question I had. It's not generally recommended because of our low risk, and then it's a variable effectiveness it's not always 100% effective, and so and it interferes with the skin test, so we don't do it in the U.S. Because, it seems like that would be I think if we became epidemic, then we probably would start it again. The problem with this is that it can take 2 months to show up on your skin test. So sometimes that can be a problem in the meantime. So, like I said, people have a positive reaction and know they're going to have a positive reaction from the vaccine or maybe having been exposed. Instead of when you signed up for school here, they'd go get a chest X-ray instead of a skin test because they already know it's going to show positive. So they just get a chest X-ray that shows whether you have TB in the lungs, and then that's how you get cleared. Sputum smear. Sputum is how I put it earlier. It's a nice big word for spit or saliva. Spit is good because sputum sounds kind of similar, but they call it a sputum smear. So they take some of your saliva and test it. If sputum test is positive, they will put you in isolation because that means it's active. Okay, so screening tests, questions, and kind of what we talked about the last time: persistent cough, night sweats, fatigue, fever, weight loss, and what kind of treatment. You want to know if they were actually treated to take care of it. So things that can cause concern is, like I said, travel to foreign countries, housed in high-density areas like jails and skilled nursing homes if they're not, highly well managed. HIV patients. Why do you think HIV patients might be more likely to have TB? Their immune system is very poor, may not be living in a real good area depending on the patient. Healthcare workers who take care of people in those kind of settings could be at a higher risk. So we basically we're going to dismiss anybody who has active disease and send them to their doctor. Oops. If they have emergent decay or something that's causing them pain and we need to take care of it, they should be treated in a hospital setting where they have ventilation and the ventilators I'll show you next time. We used to have hospital dentistry when I worked here. We had hospital dentistry. Now we kind of have the special care dentistry, but it's not the same as hospital dentistry. So I think the VA has a setup where they can do hospital dentistry and actually handle something like this. Definitely med consult, and these are the kind of respirator masks that you would wear, and that will eliminate that small droplet nuclei. The reason they'd have ventilation is to try to pull up the droplet nuclei, but you definitely have to be extremely cautious because of the infectious state, very contagious. So this is important to know. If they do have active TB and they go on medications, they want to know before you can treat them, no longer in the coughing stage, effective anti-TB drugs for at least 2 to 3 weeks, and they want 3 days in a row of a negative sputum test. So that's the criteria, and that's important. That will be, I'm not sure if it's in, I think it's in both. Usually, successful treatment requires more than one drug. So, and it's has to be regularly taken. It's same thing. The side effects sometimes are hard. So sometimes they have to do it by direct observed therapy, that DOT, where an RN or somebody actually watches the patient take it. They take tuberculosis extremely seriously in the U.S. because we don't want it to be an epidemic here. And so anybody who does contract it is usually also sent to public health, or at least their name, and they're listed in the public health setting. So those are some of the most common meds. Rifampin is one. I don't know, did Dr. H talk about any of the TB drugs at all? Not too, okay. And for active disease, it's a really long time. 4 drugs for at least 2 months, and then less drugs for 4 to 7 months after that. So it's about a 9-month therapy if followed correctly. And if they're multi-drug resistant, then it's 7 drugs for 12 months. That's a lot. Latent TB. So let's say you go to Africa and you come home and 6 months later you have a positive TB test. And you go, wow, I must have gotten infected in Africa. It's latent, but I don't know if it's ever going to become active. I'm concerned about that. Usually it can become active within about 20 years. So if you wanted to clear that and clear the bacterium from your body, you can also do 1 drug instead of the 4 or the 7. You can do 1 drug for 6 to 9 months, or the other one for 4 months. And then that usually is quite effective. Problem is the side effects are what people don't like. You can have liver problems, severe liver problems, flu-like symptoms. Nobody's going to want to take a medication that makes you nauseous or vomiting, diarrhea like flu for that many times. You will want to know that rifampicin, that's one kind of drug, causes orange color body fluids. Tears, saliva, everything. Orange color, yeah. So just, that's something, they have it in the board books too. So TB medication, specifically rifampicin, causes any body fluid to be red-orange. Kind of interesting. Okay, so basically if they had a past history of TB, there's no concern. You do not have to be worried, and we are going to be able to treat. You just want to find out when it happened and the kind of treatment they had. Okay, so, okay, here's a couple questions. Oops. Yeah, we just talked about this, but there's one little detail in there that makes a question. It's not really a statement in my opinion, but that came out of your books. Well, it kind of is. Okay. Why is the reason... Okay, the reason's correct, except for why is the statement incorrect? What little piece of this statement? I wish I could move these out of the way. How long does it take to be safe to treat? Yeah. 3 weeks of medication, that's it. If they follow it carefully and they quit coughing and they have 3 sputum tests that say it's inactive, they have to keep taking it, but they're safe to treat. We want to hear that from the doctor. We don't want to just hear it from the patient. We want a clearance from the doctor. But in 3 weeks, actually, if they're on the appropriate medications, no longer in the coughing stage, and have 3 negative sputum tests. Okay? That's the criteria. So you very likely could get something like this. Okay? So you want to be clear on that. Okay. See what our next one is. Because we don't want to make the mistake. Well, I better wait till you've answered this. A few more. Okay, good. We don't want to make the mistake either of not treating somebody or sending them away if they're safe to treat. Okay, because there's no reason to not treat them. Okay, let's go back. Okay, I'll let you review that. I'm not going to show that video. We showed a good one at the beginning. Okay. Okay, just like the raise of hands, everybody knows somebody with asthma. And probably if we got to hear everybody's reason, there's different reasons they have asthma. My son-in-law's, it's triggered by cats. So they never can have a cat in their house. My daughter's relieved that she has a good reason. But I love my cat. Love my dog. So, okay. It's definitely, a lot of children have it. Working at the school, I had a lot of inhalers in my desk with all their names and everything if they come in from recess. Often it's exercise induced as a child. More males have it as kids, more females as adults. Selena, did you have something? Oh, okay. I thought you raised your hands. Okay, so there's two things that cause it. Bronchospasm, so that's where it actually, the bronchial has a spasm which tightens and constricts the space, so the space is smaller. And then they have a narrowed air, so that's narrowed airway space, and then they have mucus collection. So the combination, or sputum plugging, so sputum also can be from the lungs too. So actually it's not a problem for inhalation, it's just that they can't exhale completely. So that keeps you from being able to inhale correctly till you have to exhale to inhale correctly. But the important part about this disease, unlike everything else, is that your lung and airways are normal in between. And that's why we could have nitrous, because a patient's lung and airway is completely normal. And if we're, like the video we watched at the beginning, that was caused by stress, fear, that could have been maybe bypassed by having nitrous. So if that helps you remember that. Everybody's seen this: shortness of breath, wheezing, coughing, just kind of desperation to get a better breath. Different types of asthma: extrinsic, that's definitely caused by especially allergies. Intrinsic, that's stress. Drug, we'll go through it really quick. So extrinsic is allergy, inflammatory responses, just like my son-in-law is talking about cat's problem. So some people can be allergic to dental materials. That's why that question, is there anything, have you ever had an asthma attack in the dental office, could be related to exactly that. So it could be that, or it could be fear. And so it might be, that would be a great question to ask. Because if they say, no, I've never had one, and they're 70, you're looking at it being pretty safe to not have one in the dental office. It's not triggered by something we do. Intrinsic, that's what we watched at the beginning. That was done by, caused by fear and stress.
When you say dental materials, do you mean like some kind of powder?
You know what they say? Yeah, allergies to the different types of materials that we use in dentistry. It could be something the dentist uses, probably more likely something they use, or as we're going to talk about, it could be anesthesia too, but usually a material that is in the dental office. There's a lot. You're going to learn, if you're not a dental assistant and haven't been, this summer you get to learn about all the different materials dentists work with. And often people who have other allergies, outside allergies, are more likely to be allergic to things in the dental office. So that's kind of good to know that too. So this intrinsic is definitely the one we would be somewhat concerned about. This also, so this is all those bolded ones. You definitely want to know this. So drug-induced asthma, aspirin, like we talked about. People are sensitive to it. Asthmatics are sensitive to it about 5 to 15%. That's pretty broad, but that's about 1 out of 10 of people with asthma are sensitive or could have an allergy to aspirin. So it's something we want to be aware of. Other substances are things that you hear about anyway, nuts, shellfish, strawberries, milk, food dye, all those kind of things, which isn't something we're going to give our patients. This last one is something that we may give our patients, and it's called metabisulfite preservatives. That can be in foods as well, but we use it, so sulfites. Metabisulfite is a preservative for epinephrine in our lidocaine. So it keeps the epinephrine alive and well in our local anesthetics. So sometimes we'll use a shorter term of sulfite. And you've probably heard of sulfa, so we'll talk about that.
So is sulfate different than sulfite?
Yes.
Because my inhaler has sulfate,
Okay, interesting.
but I'm allergic to sulfa, but they're all different.
Yeah. What is sulfa? Do you know?
Well, mine was the antibiotic.
Yeah, sulfa is an antibiotic. I actually have you're going to write the difference between sulfa and sulfite, because I can't tell you how many times people get confused about that. That is confusing. They're so close. And sulfa is not a type of sulfite, and sulfite is not a type of sulfa. So what I really want you to basically say in that breakdown is sulfa is an antibiotic, sulfite is a preservative. They're not similar at all. They just sound similar. Yeah.
What about sulfate?
That's what she was just asking. I'm not sure exactly what that
Preservative as well.
shampoo is what you said. What did you say, Tricia?
I think it's a preservative as well.
Okay, it may well be. I don't know exactly what it is, but I bet it is. It's not sulfite, or they wouldn't put it in inhalers. It's not the same. So hopefully those pictures stick in your mind. Put those with asthma, aspirin, and the metabisulfite. But I'll take sulfite if you were ever to answer that. It's something we would want to verify. Most asthmatics are going to tell you if they have a sensitivity to either of those, because it's going to have been a bad experience. Exercise-induced, that's what we talked about with the kids running around at recess. More likely in young adults. That sure looks fun, though. I think we should all be there instead. Up here. Where is that? Does anybody know? Yeah, I know. Canada is what it looks kind of like Lake Louise, but I think the mountains are different. Has anybody been to Lake Louise in Alberta? Oh, you guys gotta go there when you have lots of money and you've gotta travel. Gotta go to Lake Louise in Alberta. It's one of the most beautiful settings. Okay, so status asthmaticus, you already have this figured out. Fortunately, it has the nice word in it. Just remember again, status continuous. It's extremely dangerous. Asthmaticus, and there's videos on that. That's it's really scary to watch. People are really struggling to breathe. So it's just a life-threatening, same as status epilepticus, and it's where they just the condition is worsening and worsening, and they're not getting results from what they normally would get results from. Okay, so this makes sense. Asthma has two types of treatments or medications. Bronchodilators, because of those bronchioles constricting. So one aspect is a bronchodilator. The other one is steroids, which reduces inflammation, which means the mucus plug. So it's going to be either one or the other, or a combination of. Okay, you probably learned a bit about that, so we talked about that. Signs and symptoms of an attack. I read through these and I went, we would all recognize somebody who's having an asthma attack. They are panicked, they can't breathe very well, they're wheezing, shortness of breath. The things that we may not know is that, okay, they have a higher respiratory count, but it makes sense because they're breathing rapidly. and their heart rate's going to go up. Well, that makes sense. They're afraid and they can't breathe. So profuse sweating. One thing that you probably, accessory muscle usage where they draw in, that's what happens when they're trying to breathe, just drawing in. It's kind of a typical sign, kind of like somebody having severe angina, heart attack. They put their hand to their chest. Okay, we already talked about this and you guys did well. When, what, have you ever been? Let's see. Do you have it with you? How often? Yeah. That's the last one's good. Have you ever experienced one with a local anesthetic? Okay, okay, so if, let's say you're going to do a health history on this, and I'm going to, at the end, I'm going to say, what modifications would you have for this? This is a good sheet for it, a good reminder. Number one thing, after you've asked your good questions, is do they have their inhaler with them, and where is it? If they're a severe asthmatic and we think there's any chance it's going to happen, I have them get it out of their purse and put it on, or whatever, wherever, if it's a male, out of his pocket, and put it on the counter. If they haven't ever had one here, then as long as I know it's with them and it's in their purse, that's good enough. So verify they have it with them. Avoid aspirin. You just want to ask questions. We're not going to avoid local anesthetics. There's a question in there. I don't want you to say no to this. It says, if you have confirmed that they are not allergic or have a sensitivity to sulfites, what sulfites again? What is it that we use? It's a preservative for what? What in anesthetic? Only for epinephrine. So if we've confirmed that they don't have a sensitivity to it, can we still use local anesthetic, lidocaine with epinephrine? Yes, the answer is yes. We can still use it. You can get in the tendency to think, oh, it's just safer to use a plain for everything. But it's not the better choice. Don't get in that mind frame where, oh, I just want to play it safe. You're not going to have as profound of anesthesia, and you're not going to have the reduction of bleeding. So it's still best, if we can, and we verify it's safe, to use vasoconstrictor. If you notice when you give injections to each other, you use plain, and it doesn't last as long. And it's not as profound. Definitely isn't. So don't make that mistake to just, oh, well, we'll just play it safe for anything. Use it within its realm, cardiac dose if they need it, whatever it may be, but use it. But if they do have a sulfite sensitivity, what are we going to use? Can we still give anesthesia? Yes. So what are we going to use? Non-epinephrine. It's the epinephrine that needs the sulfite to preserve it, not anesthetic. I had one person say we can never give them anesthetic. What if you need your tooth pulled? Of course you can have anesthetic, okay, and you need anesthetic. So it's just that we're going to switch the kinds if necessary. We always have some other options too, but if they need anesthesia, they can have anesthesia. Okay, the board books talk about avoiding ultrasonic and air polisher with any of the respiratory diseases. However, again, with asthma, we're not having people who have, unless they're having an asthma attack, which we're going to stop treatment. So remember that for boards, anything respiratory, but you don't need to come to me and say, they have asthma, should I not use my ultrasonic scaler? I'd say ask the patient if they mind if you use it, if it's any problem. Sometimes they can choke on something and maybe trigger something, but don't eliminate it as an option. Does that make sense to everybody? Okay, if somebody has difficulty breathing when they come in, we probably won't use it. All we're going to do is trigger that, and it's going to be terrible for them. There's some older people who simply can't tolerate it. That's why you have to know how to hand scale really well as well. Sometimes you might need to give supplemental oxygen. Okay. Good idea to rinse after inhalers. Anybody who has it probably knows that. And candidiasis is the fungal infection most likely associated with having to use inhalers. Xerostomia, okay, all that makes sense.
I have a question.
Yes.
So the ultrasonic, is it a 100% contraindication if they have asthma not to use the ultrasonic? Or is it depending on...
That's what I was trying to say.
Okay.
So it is not 100% contraindication. Boards, that's why I had an asterisk there. Boards just want you to say no ultrasonic if anybody's has any respiratory, which I don't understand that because they say nitrous is good for somebody with asthma. But no, if they're okay right then and they've used it before, I would use it then. There are some people with mild COPD that we use it on. So really asking the patient is the best case. But for board purposes, if they're having any kind of difficulty breathing, then you're going to say it's a contraindication. But it is not in day-to-day practice, especially asthma. COPD that's moderate, it would be a 100% contraindication, yes.
I know that my patient yesterday had asthma, and with the ultrasonic, I used it on her, but it was just, like, I had to take quite a bit of breaks. Like,
Yeah.
I couldn't because it was affecting her breathing.
It was.
But, yeah, but overall, like, it was just sitting her semi-supine and just having her and tell me if she needed to stop.
It's so hard to know for sure. Some patients just have a hard time with ultrasonics, or they have a hard time with swallowing. Older people, they have more and more what we call dysphagia, difficulty swallowing. They can't swallow right, so it triggers a cough, and then once they get started, you can't do it. Exactly what she said is, one, check with the patient, but putting them semi-supine, and that's the kind of patient I'd want somebody to suction for me, if at all possible. Or I'd take a lot of breaks, and I'd be really in charge of my suctioning, and really be aware of the patient. And if they're struggling at all, you get out. Sometimes it's just not worth it, hand scale. It just depends. But it's hard to say if it was her asthma that was a problem or other things that were triggering it as well. But certainly once they get started coughing, you've heard those patients. Sometimes I stop and I'm like, is that patient going to be okay over there? And it's usually an older patient who struggles. So we really need to be aware of that. That was good that what you did. Just you have to stop a lot. Sometimes you think, okay, it's going to take me less time to just hand scale than to stop every couple of minutes, or not even minutes, seconds, really. 20 seconds of water spray. Okay, I'm going to wait on that. Okay, there you go. Which local anesthetic is recommended? Plain, some kind of plain. Doesn't even matter if it has less or more epinephrine. Okay, we're going to go through this really quick. Irreversible. This is how COPD is different than asthma. Irreversible airflow. Bronchitis and emphysema. Cigarette smoking. We already talked about that. Definitely high. But when you get down to that fourth one, 1, 2, 3, 4, 20% of smokers develop COPD. So 1 out of 5 approximately. Eventually. That is pretty high odds. Kills a lot of people. 4th is pretty high. Cancer is 3rd. Cardiovascular is 2nd. Obstruction. Okay. So here it's inhalation and exhalation. So this is layman's terms, and I think you'll see this in your board book. But just a visual to help you see, I just pulled this from images, but blue bloater is considered chronic bronchitis. Emphysema on the right is considered pink puffer. Who came up with those? But that's the combined thing that goes together to make COPD. And but the person on the right, doesn't that typically make you think of a smoker who's over years and years, and they get kind of a barrel chest, but they're very thin and have difficulty breathing. There it is again. Okay, I'm going to move quickly. Really what you want to do is determine, okay, here's the most important part. Med consult required if COPD is unstable. So if they have severe short of breath, coughing, and on a lot of steroids and it's still not working, it's problematic. If they're somewhat controlled, semi-supine position. Okay, no problem with vasoconstrictor for COPD. Nitrous is avoided. Avoid ultrasonic. Even avoid rubber dam. Do you guys know what a rubber dam is? Okay. Still use them sometimes. Endo, they use them a lot. It isolates a tooth, but it can make people who have difficulty breathing feel very claustrophobic because they have rubber that stretch across their whole face, for those who haven't ever seen it or had it done. And then they isolate the tooth to keep it dry. They do it for endo. Okay, cystic fibrosis. Anybody know someone with cystic fibrosis? I do too. That's a very rough disease, and it's disorder of the exocrine glands. When our baby first, they weren't sure why she wasn't thriving, and failure to thrive. They sent us down for a test for cystic fibrosis. That was really scary. So I learned the most about it then. But basically, their lungs just fill up more and more with mucus collection. Spider or ant? I did too. The way it went. Yeah. We're talking about it. Oh no, we're talking. Did you guys get it? If you give me a shoe, I'll get it.
Where's the spider? They don't know where it is.
Okay, time to go. Look at your case study at the end of Okay, have a great afternoon. Have a great morning. Guys, this lemon is surgical.
Miss Hayden, why does it say more young for kids, like more boys will have it, but then more women will have it? Does it just resolve on its own?
Yes, they outgrow it. It's actually, that's the kind of asthma you almost want to have is, if you have to have one as a boy and you outgrow it. My nephew is like that. He had it severe as a child, but as an adult, he rarely has any problems with it. So that's and I think it leaves the women with it because more boys have it. I don't know everything about the stats on that, but that is the main reason. Have you had problems with it? Yeah,
I was curious.
Yeah, I know. I wondered those things too.
Great, thank you.
Yes. Hello.
Hey, I had a question for the test health history questions.
Yes.
For that exam, were we supposed to answer or ask questions only for the things that were in red, or for all yes?
All yes.
I think that's why I didn't do good on that exam, because I only asked questions for the things that were in red yeses.
Oh, yeah, that would be good. Yes.
Okay.
I don't know.
I didn't realize it until right now. So
okay.
Navigating.
Yeah.
I mean, I still have a good grade in the class, but I just I didn't realize it until right now.
Yeah. Everything. All yes.
Okay.
Answers.
Got it. Okay.
So that will definitely help you in the future.
Okay.
With and
Yeah, I think the red threw me off a little bit. Yeah.
Yeah, it's what Axiom does.
Okay.
It reads. I didn't do that.
Yeah.
It reads the things that are. It considers more
Got it. Like an additional.
Yes, a higher risk.
Yes. Okay.
And so I noticed that and I went, that's interesting. I hadn't really noticed that before.
Yeah.
That other yeses, I mean, aren't not necessarily.
Because I got my grade back and I was like, I feel like I didn't do that bad. But then I just realized right now, I was like, I think I only asked questions for the things that were in red. So that makes sense.
I said, several students like there weren't that many answers,
Yeah.
Yes, I mean,
Because
that
when you were
many
going
questions.
over it, I'm like, I don't remember.
I don't
seeing
remember the
that on
GERD.
there.
I didn't ask
any GERD questions because it wasn't in red.
Okay, and that's where.
Yeah.
Yes.
So yeah.
I don't think I did either.
Decision because I found them red.
Yeah.
My bad.
Yeah.
You mentioned yesterday. I was thinking about it. What did I do?
Maybe I'll look back on
I did the same
that.
thing.
That
I just
actually
realized
helps
that.
me understand why people just left it blank. I mean, I did list underneath what would the additional questions be for GERD, for this. I did list that, which it should have triggered.
Yeah.
But maybe.
I don't know for sure. I can't remember.
Now, there were several who just didn't ask any questions about certain things, and I was confused by that. And if that's probably
I don't
the
remember what it
explanation.
was, but some of the things you went over, I was like, I don't remember seeing that.
Yeah.
I don't know. It could have just been stressful.
But yeah, I just wanted
No,
to
because
see. I
it
didn't.
did, I mean, I can look. It would take me a little while, but I'd be happy to. It's really easy for me to print out. I mean, if you have the time, I could look really quick, and that would give me an idea. Yes, and I have it.
Thank you so much. The pink one. Thank you.
And so I need to look at it.
Yes, you need
I
my
could
patient.
actually grade it probably just for an axiom, but I haven't had a chance yet. But I will do it. And if I have any questions, then I'll come to you and ask. She was thinking the same thing, so let me just look. I bet that's what it was. Okay, let me just show you guys. I mean, I know you probably don't want to see or have everybody see.
No, I mean, I don't mind at all. Yeah.
For the Selena and I had a question. We couldn't find you last week.
Did you want to just sit here and look at yours and then see if that's what you think? It might be hard to tell just like that. And
After today that you mentioned,
you're pretty sure that's what it was.
Sure, because
Okay.
I'm pretty sure I did for the seizure and for the other one too. That was close to seizure, but for the rest of the yes, no.
That weren't red.
Yeah. That's it.
Okay.
I'm trying to remember the question regarding. I know the answer was Andy and I'll